before we move on. And I know the charts don't have page numbers, so I quickly numbered them because I'll need you to probably pull them up. When we talk about, where am I going? I'm sorry. I apologize. When we're talking about the hospitalizations, it's chart 12, comparison of social distancing scenarios. And we talk about the no social distancing, 25% and 35%. My first statement is that's great. We've got plenty of capacity. Because as the mayor stated when he started is we're not avoiding people from you're all going to get this at some point. So, we know we're going to get it. We just don't want to over inundate the hospital systems. We want to give you the best tools ever to make sure that if I need it or you need it or our brothers and sisters need it, that capacity is there for us. And so based on these numbers, peak hospitalization, 725 is pretty darn good. I mean, that's within our means, isn't it? What am I missing with this chart?
Councillor, with regards to volume, I think your estimate is right on. 725 excuse me, is a volume that the hospitals can currently handle. I mean,
could you state your name for us, please? Sorry about that.
My name is Jeremy Cowles. I work for Sanford Health. And I think as you go into that, this was the goal of social distancing as a whole. It was never to eliminate disease. The number of people under the blue curve and the number of people in the green curve are the same. It's the same number of sick people. And if you go for the other curve, the orange one that was really, really high, it was still the same number of people. The important part is, can we bring the volume down to a point where the healthcare facilities in town, Sanford and Avera primarily, can do the work that we need to do and keep people as safe as we possibly can? And my estimate is the same as yours. In the work that we've already done, with the current 25% we're already at, we can get to 700-ish inpatients for those two hospitals, and we can make that work. We can make that work with our existing business of heart attacks, strokes, deliveries, those sorts of things.
Right. I mean, I think that's really positive. I mean, because we don't want you to be over inundated, and so it's clearly showing what we're doing is working. It's clearly showing that the 25% reduction in social contact is working. The other thing that I'm going to just make a comment on too, on page 18, I don't know, slide 18, what is 35% social distancing is the chart. I don't know if Tom can flip to that or if somebody can flip to that just so you see what I'm seeing. It says the school closings restrict to less than 10 persons, and then the 65% on that. The thing that I don't think it takes into account, and I'll ask Eileen if she wants to comment on that, is this is plus all non-essential employees stay at home. So that's really that really heavy-handed stay-at-home order, okay? If we're making everybody stay at home. But what it doesn't take into account is I could name you at least 30 businesses currently that are non-essential that have chosen to close. So that may be in fact that 65, but we've got to close that gap that while we're at 25%, the goal is to get to 35, we might in fact be more at that 32% because I have at least 10 hair salons that I know are physically closed. The nail place I go to is closed. Many of the gyms are closed, minus one in particular has chosen to stay open. I won't name names of businesses, but also many restaurants have chosen this time to close down and do some remodeling that they thought was, hey, now's the time to do it. I'm going to keep my employees on board, and we're going to redo the floors and paint the walls and do whatever we want to do. And so if you take all those businesses into effect, I'm not buying this chart because the chart is okay if that were in fact all non-essential, but we've got to close that gap between the two of all those businesses that have voluntarily closed. we're over 25%. Let's be clear in that social distancing, and the goal of 35 is a little different in my opinion, because of all those that have already closed. And that's the issue I have with this potential chart and some of the data presented. I'll reserve the other questions for now.
Any other counselors have questions? Anybody on the phone? Okay. Counselor Neitzer?
I guess I'll.
Did you want to
I'd like
speak to this last
let
item?
Dr. Vasil speak if we could,
Oh,
yeah.
I'm sorry, come on up.
Dr. Pazel with Avera Health. So I wanted to respond to a couple of those questions asked earlier. So first off, thank you. We were involved in the process of presenting these numbers, and we used several of our PhD epidemiologists and stuff when we were coming up with these numbers. And to the point of, do we think that these are extreme numbers? Where do we feel that these estimates are? These are pretty much a midpoint number between high numbers and low numbers, so they're kind of middle numbers. And in fact, what we're seeing, to the point of, the effect of how many you're testing and stuff, how that affects the numbers, the one thing that is very objective in these numbers is the number of hospitalizations, because that's something that doesn't depend on the amount of tests you're doing. If people are sick enough to be hospitalized, they're sick enough to be hospitalized. And so that's the most objective evidence that we have on which one of these curves are we going to be following over time. And so that's the one that has the most effect on these projections. And I can tell you right now from Avera's standpoint, on our half, we're essentially half of the volume within Sioux Falls. We are exactly tracking, our hospitalizations are tracking these charts pretty much exactly, give or take a couple hospitalizations from day to day. It's been pretty remarkable how much they're tracking. And so I do believe in those numbers. And so I also agree with Dr. Caldwell's when he says, at the 25% curve, I will argue with you, we seem to be on the 25% curve right now. That's where our hospitalizations are tracking. And at that, do we have a plan in place that we can manage the capacity, the 750, 800 hospitalizations, the 150 ICU beds? Do we have that many ICU beds in place now on that 25% curve? Yes. However, is that well beyond anything we have ever done in this city as far as managing people? Well beyond any number of ICU patients we've cared for in this city before. Do we have a plan to try to cover that many? Yes. Are we comfortable with that? Especially at the same time, we're likely to be losing 20, 30% of our hospital staff to the illness itself. That's a difficult statement to make. And so that is why, the 35% numbers, we will take any and all help we can get. Because do we have a plan? Yes. Is it well beyond anything we've done before? Yes.
Thank you.
Thank you.
Do you have a comment as well?
So one of the things I think I want to point out, and don't get me wrong, I am more optimistic today than I was a few days ago because of this work that's been done. But I think it's really important when we start talking about the number of people that will be infected in the hospital, we're talking about only what we've calculated for Minnehaha and Lincoln County. You have to remember there's going to be a surge beginning in the rest of the state when we're hitting our peak. Okay, and so many of those people will be coming to Avera and Sanford health systems and other health systems, the VA, et cetera, in our community. And so you have to keep that in mind. Our job is to think about our area, but we also are going to be impacted by outside of Minnehaha and Lincoln County. So please don't misunderstand when we say, and I don't disagree with anything that's been said thus far, but I just wanted to make sure and point that out. So.
And that's something, if I can just follow up with that, that's something that Director Franken and I have talked about in great length, where I said, what about all the people that are going to come here? Because we've already seen people flown in to the hospital systems here from other communities. And we'll continue to do that because we have phenomenal healthcare systems here, and we should be taking care of those, but we also want to make sure that we're mindful of that. And so as the curve here in Sioux Falls peaks before the rest of the state, that might not be a bad thing either, because we can try to take care of our surge before the others. And it's such a weird statement to make, to say, and it sounds super insensitive to say, we're hoping that the death rate is little as possible, because we know you're all going to get it. We're not able to prevent people from getting it. We want to slow it and prevent those from really getting it all too fast. We want you to get it all nice and slow, which sounds crazy to think that that's something that we're talking about at this time.
Can somebody skip to what I believe is the last?
This is,
Oh,
Sorry, my name is Jeremy Cowles again, with Sanford
Peak
Health.
infection one,
But if you
slide
can get
19.
all, keep going. Keep going. There it was. Back to. Back to. One more. Sorry, another one. That's the one right there. Sorry, this one is one that I included that I'm not sure that I wasn't sure we were going to need. This is a model for the state of South Dakota. We've obviously been in conversations all over the state and all over several states in Sanford as well. And I wanted to bring this one up particularly because it makes a prediction for bed needs throughout the state. And what you see in this particularly is that there is 2 humps on this. Part of Sioux Falls going earlier in this curve is the fact that we actually do a little bit of getting out of the rest of the state's way in making our peak before the rest of the state peaks. We actually believe that may be a bit of a help to us in taking care of the state as a whole. We believe that by running through some of the illness that we can get and get the people of Sioux Falls back to healthy sooner, we may have a better chance to treat the other people from the other parts of the state that have to come into us later, because the rest of the state is lagging behind this curve. Forgive the rest of the busyness on this slide. What this is a computer model that's been run 50 to 100 times, plotting the possible illness every single time. The dark blue line there is the middle of that curve. The lighter dark blue line that's sort of below that is a lesser estimate that's probably closer. And all of the gray lines are the computer simulations as they run through. I didn't include a bunch of plots like this because they tend to get a little busy. Other questions regarding the state involvement with the rest of us?
Mr. Mayor, do you have something to add?
I did, not for Jeremy, but Eileen, can you go to I think the slide right before this? You didn't show, but you had it ready in the can. That shows that gray band of that capacity, this one. This is one he didn't show yet. I wasn't sure if this was something we were going to show or not, but this band on the screen, this shows the bed capacity or the capacity of the 2 systems right now based on where we're trending. And this is data that we've now seen in the last 2 or 3 days that's driving some of the decision making. So you can see right now, if we don't do anything else, if we don't put in any new ordinances, if we don't employ any new tactics, we're knocking on the ceiling of complete capacity. Okay? And as Dr. Basil said, it's like, do we have the capacity? Yes. Is it unprecedented, like probably nothing we've ever had to do? Yes. So the question we have in the following, and per my opening statement, was, does a stay-at-home order move that down? And it would, but at what expense? And are there other now strategies, now that we know that we're knocking on the ceiling of that band of capacity, are there other things that we could do that would still help free up a buffer and some capacity to give them a little more confidence and breathing room without a stay-at-home order or something that many people feel is too restrictive? So I want to be clear on that's why the situation is so fluid, the data is so fluid. This is what we've been looking at the last couple of days to say, okay, we think there's maybe a win in here somewhere in the middle. That still puts public health and public safety and lives number one, but also takes into account all the other factors, the ancillary factors and the unintended consequences of a stay-at-home. So I think this is an important slide to look at.
Okay. Councilor Neitzer and then Councilor Kiley, you'll be after that.
Could somebody help me with the hospital bed issue? And first of all, I understand that, it really comes down to how you define a bed, because obviously some maybe have certain equipment, some may not. Of course, you have to have the staff to take care of the patients in the bed. But I've heard a number of numbers, and I'm hearing another new one today. The first was, I thought we had something like 545 or so beds at both hospitals certified, and that now we've increased to, by clearing things out, because we literally have workers, I think, being furloughed and nurses sitting at home doing nothing, and we have like 800 beds now between the two. And I've also heard maybe we're making changes so we could go up to 1,000 or not between the two, but each. So, and then I'm hearing the 700 total, that would be 350 between the health systems. So somebody help me with all of these numbers. Where are we getting this? We only have 700, and are you taking into account all of these things you're doing to add capacity in expectation of this surge?
So Mike Wilde from Sanford Health, and I hopefully can sum up everything that was just put out there. We are, speaking for Sanford, we're licensed for 545 beds, which is our usual publicly reported license beds, and there's regulation within that we have to report. We are always planning on surge. That's part of our obligation as a healthcare provider. And we can surge to the point of our physical space in addition to our staff. So where we're at Sanford is we anticipate the ability to provide care in the moment for far more than 545 people. And what you see, the numbers there are the numbers of COVID admitted patients, but as Dr. Cowles alluded to, there's also just our regular ill patients that we're currently caring for on top of that. And this past 30 days has given us a pretty good number where we're going to be at from that standpoint. So working with our facilities, both in and outside of South Dakota, or what we call our network facilities, and transferring between that and the surge within the hospital here in Sioux Falls, we do feel we can meet these numbers, but we're close. And in terms of our staff has actually been, we have not furloughed or anything of that nature. We still have our staff. Some of them are certainly not doing what they once did, for instance, screening and things like that, but we have a lot of staff that while they may be a nurse in a clinic, they're learning how to be a nurse in a hospital right now as well. And so we're doing what we call cross-training with a lot of our staff in preparation as well.
Okay. What percentage of admitted inpatient COVID patients are likely to go on a respirator?
I don't want to be different than the data that was presented, because I think that was up there, if I remember right, wasn't it?
Was it on there? Yeah, if you could. And then, do we foresee that we have the capacity? Do we have the respirators we think that we're going to need?
Yes.
Do we have them now?
Yes.
Okay.
Did you have a comment on that?
Like he might have if we could maybe let him comment as well.
No.
So the answer to the question of what percent, it's usually pretty standard, between 25 to 30% of patients hospitalized are going to need the ICU, and 75% of those will need the ventilator. And so the numbers that are out there, do we physically have that many vents within our two systems to hit that number? Absolutely, that answer is yes. Is that number well beyond any that we care for on an ongoing basis? The answer to that is also yes. So, okay. Same sort of thing. Do we have cross-training going on so that we can handle, multiples of these numbers, so that no matter what comes in, are we preparing to meet that number? Yes. But is that going to be at all comfortable for us, or anything any of us has actually done? No.
Okay. Maybe the next question I have is, I'll call it maybe one of the biggest questions I have is, I'm finding a bit of a disconnect because I continue to hear the governor and the Secretary of Health, including the governor this morning, talking very confidently that we have the capacity, we're doing good, we have all the beds we need, and then locally I'm hearing we don't. Can somebody please square that for me? Especially when you say that the state is working on these numbers. I'm hearing, we're saying that we have to keep pushing and we need more, and they're saying we don't.
I think the state is going off of what we gave them as our maximum capacity numbers. And according to our maximum capacity numbers, we can accommodate that curve. I think what you've heard from both of us is that those maximum capacity numbers would be unprecedented. They would be something we've not put into our hospitals before. Can we plan for it, train for it, get ready for it? Absolutely. Is it something that we did yesterday? Absolutely not. And so the question of can we do it, we believe the answer is absolutely yes. The same question has to be asked of my friends across town, because both answers have to be yes if we're going to be able to pull this off. But at the same token, the governor asks us if we can accommodate that sort of thing, and we start working and training and moving forward to say, when people come, we will have the ventilators available, we will have the beds available, and we will have the people available to pull it off if we need to.
Okay, that's fair. I struggle both ways between, I'm always skeptical of models, so one of the questions I would have for somebody to answer is, what is your confidence percentage, perhaps, that you think you're going to hit this, versus us going through this and we only hit 50%? I mean, it's a projection, but we are being asked to hollow out our city and our economy for a projection, and so I'm looking for some confidence level.
So we have a phrase that we use, tongue-in-cheek, called the best of the worst. And that is the curves that we run off of. What's our best estimate of what the worst case scenario is? And I will tell you that we then take that number, compare it to the city's number, compare it to Avera's number, and see how close we get to. And we're close enough that we felt like the presentation in front of didn't need my presentation and Avera's presentation to compare numbers that were within 50 of each other. But that being said, we feel that that is the numbers of the worst case scenario that we have to prepare for. Do I think we're going to come in low of that? I certainly hope so. I don't hope so because of the hospital. I hope so because of the sick people. I hope so because there's 5 people in my family, and if COVID hits somewhere between 20 and 80% of the people in the country, because that's the error bar that people are giving us right now, 20% is one of my kids. 80% is everybody except my wife. She's the toughest one. Christine laughs, she knows my wife. But that's the uncertainty we're dealing with when we're dealing with numbers like this. But if you compare New York and you compare the data there, and you compare the data in Washington State, and you compare the data in California, where social distancing appears to be working fairly well, and you use Italy and China, we can say with some confidence that these new, the current progress that's currently up on the screen is a fairly accurate estimate to what we expect to have, and we don't expect to go over it.
Okay, you're telling me that based on the worst case scenario, which may not come to pass, that we should continue to lock down the city. And I'm not saying that to you just personally, that's what I just continue to struggle with. So.
And I understand that. We continue to struggle with that as a health system, because all of our partners right now that are out there are trying to do their regular business, and it's being hindered. And we struggle with that personally in my house and my neighborhood, and I totally get it. But I can tell you, the instant we take our foot off the brake here and we let everybody go back, that curve looks a whole lot more like the one on the left than it does like the one on the right, and we lose the ability to handle the capacity again.
And I'm certainly not even suggesting that we let off the gas. I was just thinking about the status quo. Can
I speak to that though, Greg?
Yeah, please.
I don't want to, I know Jeremy's on the hot seat with the question, and
yeah,
I'll be the candid guy, because I'm having the conversations with our executives and so forth, and that is, Sanford is confident that a stay-at-home order is not needed. They've expressed that to me. Their leadership has. their physicians have. Avera has said it certainly wouldn't hurt at this point. And we will endorse that. Sanford has not endorsed that. So there's even differences of philosophies and opinions on that. I will say that based on this new data, however, and I don't mean to speak for Dr. Basil or Dr. Elliott, but even in some communication I've had with Sanford execs or Avera execs the last couple days, and what you're seeing on the screen, I think there's a confidence level that what we have been doing is working, and now with this new data, a stay-at-home order would take us down quite a ways. There's things we could do that wouldn't be as drastic, that would give us a little bit more of a buffer so that we're not in such unprecedented times with the capacity. And that's what we're going to talk about in our next item. But I know what you're asking of him, and I don't want to put him on the spot, so I'll be the guy that shares just the cigars, smoke-filled room discussions that are being had right now and trying to figure this out with all the leadership.
Okay. In a healthcare system, there better not be smoke-filled rooms.
Well,
Yeah. No, and and thank you very much. I would just finish by saying, I've been on this earth for 41 years, and almost by and large, models have almost very rarely come to pass. So I'm going to look at the data, but I'm always a little leery of trusting projections, because many times they come in not even close to what the worst case was. So.
Absolutely. If it helps any, my chief operating officer at Sanford is getting really tired of me being right about the number of ICU patients for the last 4 days in a row. We're getting fairly good at this model at predicting the hospitalized patients. The part that we haven't seen yet, and you're absolutely right, is the number of people in the ICU. What we haven't seen yet is the biggest surge in the hospitalized patients, and I hope we don't. But the things where we really have to be careful about is the resources that it takes to take care of an ICU patient. And those are the things that are most vital to us.
Thank you.
Let's go to Councilor Kiley.
Thank you very much. Councilor Neitzer just asked the majority of my questions, and they centered on personnel.
We're losing you a little bit, Councilor, if you can talk closer to something.
Sorry, I'm as close to my computer as I care to get. Can you hear?
That was better.
My question centered on beds versus personnel versus ventilators, and I think Greg asked that question. For the most part, it was answered. However, I do say that I would have a little, I'm sure the doctors probably wouldn't want to say this, but I will. If I were a patient and I had now a nurse or personnel treating me or caring for me that has just been cross-trained in the last few days versus personnel that's been doing this job for 10, 15, 20 years, I'd have a little bit of concern. But I guess it is what it is, and I do appreciate the fact that they are preparing for that. So there is that to consider when you are cross-training personnel. And I think my other question was answered during the presentation of the modeling, that the models do reflect the numbers up through today. Because I do know in the last 2 days, we have, while we're seeing the increases daily, we're starting to see that the increases are dropping over the last 2 days. Wednesday of this week, we had an increase. And when I'm talking increases, I'm talking just Minnehaha and Lincoln County right now. On Wednesday, we had an increase in infections of 176. Today, that increase was 98 for both counties. I hope over the course of the next several days that we continue to see that type of decrease. But I just wish to confirm once again that those numbers were factored into the modeling we just saw today.
Counselor, can you ask that question again? And then I'm also going to, this
Take
is
your
Jill.
mask off, Jill, so we can hear you better. There you go. Sorry.
Might need you to repeat that question again, Counselor Kiley, but I also want to offer that Dr. Amy Elliott, who's a doctorate in epidemiology, who's on the call with Avera, and so I wouldn't mind her sharing some thoughts as well and give her the opportunity to do that. But at first, if you could repeat the question, and then whoever.
Okay, and you were kind of fading in and out a little bit there. And sorry, I'm on a computer, so I can't see speakers coming forward to the mic. I'm still looking at a current progress graph on my computer. The numbers have the increases that we've seen over the last 2 days. Well, we're seeing increases, but it's dropping. It was 176 additional infections for Minnehaha and Lincoln County on Wednesday. Today we had 98 new infections, so still an increase. Today it was an increase of 98. I just want to make sure that that is reflected in the modeling that we saw today. This tapering of the number of increases on a daily basis.
This is Mike Wilde from Sanford. No, the last 2 days are not reflected in the modeling. And if I could just make a comment that you had made in regard to your cross-training comment. The cross-training we're doing is nurse to nurse, and it's just really a matter of technology with an IV pump versus a clinic setting and things of that nature. So, we all start new jobs and we're all vulnerable at those times, and we all learn and improve or maybe not improve as we go through jobs. But the reality is we're doing it in as safe a manner as possible.
Understood.
Any other questions, or were we waiting for somebody else to answer? I'm sorry.
I don't have any other questions, so if Jill wants to continue.
I guess I just wanted Dr. Amy Elliott a chance to make a couple comments just about the confidence levels of the data, if you wanted to, Amy.
Sure. Hi, this is Amy Elliott. Can you hear me okay?
Yes.
Well, good. Thank you. So many good comments that have been said today, and just something I'd like to orient people to in general with these models. I think Mayor Tenhagen said this very well, that in 6 months they'll be exactly right. And so what is put forth in front of you is really information based on what we already know from the hospitalizations, things that have occurred thus far, as well as what we've seen happen in other areas of the country, and trying to combine those informations to project out to help with planning efforts. Now, these models are also supposed to be extremely fluid to...
You're fading just a little bit. I don't know if you can get a little closer to wherever you're speaking. Sorry.
Okay, no problem.
There you go.
These models are meant to be very fluid in that, changes in social distancing, for example, can really help improve that. And the way that these are best used is if you really monitor and keep putting in very real data. I like the gentleman who just spoke. I think maybe we would want to hire him as a researcher within the health systems. That you want to be able to track where things are at, and that will change the nature of the curve. Where we're at right now in this is, you can see if you draw a little line up around April 17th, and by the way, these are tracking right now. The 25% reduction is tracking with what we see in the hospitals. But as you see in that curve, we're in a little bit of a sweet spot right now. Okay, and this is an opportunity where changes in social distancing and also making sure that we maintain current, for sure, can be done now. If you go out to, let's say May 11th, for example, okay, you can see we're getting really close to the peak of that curve. Social distancing measures would have less of an impact then on helping us control that peak. And so what we're in now, while there's a frustration for lack of data that we're currently experiencing because we haven't had as many hospitalizations and things like that of other parts of the country. And we are projecting here. What we are in is this sweet spot here where we have to look at what changes could we potentially make. There is a confidence interval around it. Dr. Basil mentioned that we look at worst case scenarios and we look at best case scenarios, and then we figure out what's a realistic plan. What's put before you is a realistic plan that all of the health systems in the city have agreed on as being really a good planning strategy. But again, this needs to be monitored throughout to see if that strategy needs to change. So I hope that's helpful.
Thank you. Councilor Staley.
First of all, Mr. Mayor, I really appreciate your comments when you first opened the meeting about public health, public safety, and you stated that's your greatest concern, and it absolutely is our greatest concern on the council as well. And you put out the call last week to encourage citizens to reach out to us at one of your press conferences, and they have. I mean, this has been a high volume, high intensity communication with constituents through emails and phone calls, personal contacts. So I know we've all been listening. We've all heard your concerns. And on either side, for my part of it, I'm hearing about 50-50 of people who want us to do more, and then people who are saying we've done enough and we need to make sure we're protecting the business interests. When it comes to the tracking of groups, I do want to say that our numbers, and of course there's a lag of infection versus hospitalization, but the last few days have been cold. People aren't outside. And so I'm going to predict that coming up this next beautiful week, I shared that wonderful forecast on Facebook that we were seeing, 7-day, we're going to see some numbers increasing. And one of the concerns I'm hearing from people is that we've got big groups of individuals gathering, and there's nothing really in place publicly to address that. So I don't think we can let up and say everything's flattening out or within the control level. A few questions. Back to that, we've got 40 in the hospital, and we've got over, 1,400 cases here in our counties. 40 in the hospital. So how many people, and maybe one of the medical professionals can come up, but does that mean, how many people right now are infected? Okay. So, I mean, 1,000 verify, or what, 1,100, 1,400?
Today we have, in between Mayhaw and Lincoln County, 1,234 cases.
And of those, 40 are sick enough to be in the hospital?
That I would not know absolutely.
Well, we had,
is that correct, 40?
I thought on one of those graphs we saw 40. 40, yes. So, so that's 1,000 people who have been tested, and they're apparently healthy. Of those, what do we got? Of 1,000, 1,200 are diagnosed. Only 40 of them are sick enough to be in the hospital. So the rest of them are at home, shelter, isolating themselves, or what? Right? They're not supposed to be out. But how many other probable people are there? Are there 10,000 right now in the community? We had the one guy got up with the. How many do we think? How many people are currently infected?
So the difficulty with that question, it gets back into A, our ability to test for this virus, and B, the number of people that may be asymptomatic or have extremely minimal symptoms from the virus. Papers out of places all the way from Wuhan, China to Harvard would estimate that the asymptomatic rate for this virus is somewhere between 20% of the population and 80% of the population, which gives you a range in South Dakota between 700,000 people and 200,000 people at the end of the outbreak. So to give you a square answer is to not give you a square answer on how many are infected today. So I apologize, but I can't give you a solid number on what that might be.
So we're really kind of, as far as I'm so grateful to have this time right now because I think the public is in the panic mode, partially because they're concerned about their businesses going under, but partially because people are concerned about catching the disease. So having this information about, to tell the people, hey, you've done a great job. The social distancing thing has worked. We need you to do a little bit more, I think is going to be comforting to people because they weren't sure some people are feeling like a tidal wave's going to be crashing down on our community. And it's sounding like that's not the case.
No, I think you said it perfectly. People have done a very nice job of socially isolating up until this point. And if healthcare had an ask, it would be continue social distancing, continue to wash your hands, and continue to be home as much as you possibly can for the foreseeable future. And I'm not going to put a week or a number of months on that yet, but the work we're doing right now is doing the job we asked it to do.
Well, and what the terminology, I'm going to use that word essential. It just came up to me yesterday, but we were having the conversation about whether your business is essential. And it came to me yesterday, let's turn that around and let's say to our citizens, don't go out unless it's essential. I think our citizens really value their own independence and to say, and their constitutional rights, but to say, think about when you go out, make sure it's an essential trip. And the other thing that our city attorney brought up, I'm going to always give this back to you, Stacy, but that our citizens are essential. That word can have so many different applications. One thing I had heard is that, and I don't mean to be morose here, but of the people who go on ventilators, 50% of them will not make it.
I think that estimate is probably a little overblown. The number of people on ventilators right now in U.S. healthcare can't be truly estimated for the number of people that come off healthy, and it's extremely variable according to age. And so right now, we can't calculate that number for New York because there's still thousands of people on ventilators. So until we know how many of them come off ventilators, I can't tell you how survivable it is.
But we can say to the public, you don't want to get to the point of having to go on a ventilator.
Certainly.
That's pretty darn serious when you get there.
Absolutely. Right. It's always been very serious.
Well, it was brought up by Mr. Jones that the people who are impacted by this, and of course we've heard this before, but that if you've got a jeopardized immunization system, that you're more at risk. But I've also heard people say, and then there's also if you're over 65, apparently you're more at risk. But I'm also hearing, and our Dr. Tingley said this at the Board of Health meeting last week, but that this thing tends to affect everybody.
It tends to affect everybody. The fatality rate is different according to age. And so what I mean is there will be a number of 20 to 40-year-olds who are very symptomatic and need to be hospitalized. And that number is, in data from New York, is about 20% of the cases that end up in the hospital. And the number of 80-year-olds that end up in the hospital is about 20% of the people in that hospital at that time. This was 2 weeks ago. But the number of 80-year-olds that walk out of that hospital is very different than the number of 20-year-olds that walk out of that hospital. Does that make sense?
So you're talking about success, recovery rate.
Recovery rate.
But how about just the amount of people who get to the point, the percentage of healthy people who have to be hospitalized versus the compromised?
The compromised people are hospitalized at a much higher rate. The question is what compromised means, and we're learning that as we go. We can say that diabetics get hospitalized more than non-diabetics. We can say that people with heart disease get hospitalized more than people without heart disease. We can say people that are overweight, particularly excessively overweight, get hospitalized more than people who are not. And we're learning those things as we go to try to predict who the people are that we need to protect the most.
But and here's the balance, is that then do we say to a certain group, well, you're not in that risk factor, so you can move about freely, you can do all of your activities as if this wasn't happening, and then we'll just take care of, put these other people over here. That really isn't something you're proposing that we do.
Interestingly enough, Sweden tried it. And if you'd like to Google Sweden's death toll right now, they're currently leading the globe. They took all of the older folks and put them effectively shelter in place, and they told the younger population they could move around freely. And right now, Sweden is one of the places where you can't get a ventilator. It's the only place that's done the experiment that way. If you want to call it an experiment, it's kind of a poor word to use in this situation, but they did make that, they did try that there.
Thank you. And one more thing to address is that our state epidemiologist said last week that we are concerned with reinfection. So the question is, how does because if someone can have it, they get past it, and they can get it again. How is that going to impact us? Because we're doing the surge, and is there a chance that we do the surge and then we have another surge that we don't really know?
Right, we don't really know. We don't think so. But much like influenza, some viruses you get once, like chickenpox, and there's a good chance you don't get it again. Some things are like influenza. The virus mutates a little bit every year, and you could get influenza a couple of years in a row or a couple of times in several years, which is why we develop immunizations for those. Obviously, the goal is to develop an immunization to this as well, but at this point, we don't know if there's a reinfection rate or if that's due to them seeing two different types of the virus. There are currently 10 of them noted in the CDC's bank of information that are slightly different from one another that all count as COVID-19.
Okay, thank you. And did you have something to add?
Dr. Basil, will you come up too? You guys feel free to come nice and close and put the mics up. I know they're having a little hard time on the feed, so keep them right there, come close, and thank you.
Alice and I are a little bit taller. We'll raise the mics. That'll probably help too. Yeah, Dave Basil with Vera again. So from our experience, what we've been seeing so far, the ICU admits and the hospitalizations both, because they're tracking about the same number. About a third are people that most of us would agree would people you'd expect from influenza seasons. You know, they're 70s, 80s, and multiple medical conditions. Another third have, for something about this virus seems that hypertensives and diabetics especially seem to be at risk of it. And so I would call middle-aged hypertensives and diabetics that normally you wouldn't consider to be that much at risk. We're seeing a large population of those that are coming into the hospital. And then the other third are indeed, we're seeing 20-year-olds, 30-year-olds come in that no past medical history that have that. Now, I think you're also right in that, the ones that end up intubated do tend to be the ones that are at those higher age limits. And you're also right that you absolutely don't want to be in that population of patients. One of the biggest problems with this virus overall is the length of time that people stay ill. Influenza even, the average length of stay in our hospitals are about 3.5 days. Average length of stay for these people is somewhere around 10 or 11 days. And that's the average because a lot of people die before that. If you're going to get ICU sick and recover from this, it's a 2 or 3 week process before we can get you out of there. I don't think I can think of a patient yet. My wife is a pulmonary and critical care physician. I don't think I can think of a patient yet that we've been able to discharge who was intubated yet. We've taken, a patient or two off the vent, but they're still recovering. That's that long of a thing. So you're absolutely right there.
And with the hypertension, is that like just people being treated for high blood pressure, or just the average citizen or are we talking about someone who's battling with it are we saying anyone on high blood pressure medication is more susceptible?
It is. That's definitely one of the CDC criteria that has said they're more susceptible, that hypertensives are a known susceptible population for whatever reason, and diabetics as well.
Any other counselors? Counselor Starr.
Thank you, Mr. Chair. I think Dr. Elliott, in her comments calling in from home, I think she was offering Counselor Kiley a job more than she was anyone in the room, is how we did it. I think she missed who was at the thing, so not to speak for her, but I think that was where she was headed. Yeah, I'm thinking you're probably pretty busy already, Dr. Wilde, by the time we're done. So I want to go to that chart 11 that we looked at. This current progress is a good one, but we talked earlier in the presentation when we were looking at the numbers of, and the phrase quality of care came up. And anecdotally, living with an ICU nurse who routinely worked 6 out of 7 days that were supposed to be 12-hour shifts, that often turned into 14 to 16 hours, that to see that person after that 6 shifts, the quality of care, I know the quality of care I received on day 7 wasn't as good as probably it would, but it took that week to recover. So my concern in the difference between the 25% social distancing and looking at 35% social distancing, the human factor. You guys, and I throw this out this way, but you guys can model this all you want, but it's very difficult, I would assume, to model in the human factor for the allied health workers, whether it's the nurse, it's the surgical techs, it's the respiratory, it's the physicians as well. And if we get to the point where we're having 700 plus or 750 inpatient beds, the human toll, you know, we've spent a lot of time in the last few days talking about the economic impact, but the human toll that it's going to take on healthcare workers, not only the infection rates, but just the physical demands of gowning. I'm almost out of breath in the little bit wearing the mask today by the time we're done, let alone putting on full PPE, or someone offered me an N95 mask a little bit ago, and I'm like, I couldn't get it to seal anyway. And the testing that it takes to get that to seal, to do the job that it would do, that the paper mask is probably gonna do me just as much good. So really, what I'm trying to, I guess I'm making as much of this statement, but the difference between 25 and 30, the difference between 750 beds that we think we can do and that you can assure us, talk to me how much easier it'd be at 325.
When you get down to those lower numbers, we're getting up into closer to what our, you know, our high peak average running capability is. We're getting down to where things are closer to, hey, this is something we're used to. We're used to handling these numbers. Are they still heavy? Are they still going to stretch us? Are we still going to worry about supply chain things, PPE, how many masks, how many gowns and stuff? We're still going to be worrying about that. But you're exactly right. We're not putting people in uncomfortable situations. We're not putting people in things that they maybe haven't done for 5 or 10 years. And then there is that emotional. As I talk to residency mates that are in other cities and stuff, they say that's one of the biggest things, is that, you know, you start getting worn down after a while of this, and it's the emotional toll as much as the physical toll. But it is also, it takes so much longer to care for these patients, putting on the gowns and the gloves and then taking the hoods and everything back off, going in and out of rooms. It does take more time to care for them.
Thank you. One of the other things that I'm not sure that, Dr. Basil, you're the right one to answer this, but talk to me about testing, because that's really the basis of this model. We're still short of testing. We're still rationing the amount of tests. You almost have to be presumed to have it or have showing symptoms before we're testing, and we're still asking people to wait in lines for a considerable amount of time. So if you're already sick or you're elderly and you're sitting in a car for hours as things warm up, hopefully over the next time, but not having the bathroom facilities while you wait in line for a couple of hours, or being able to separate those. So where are we at with testing? Are we testing enough to make the model be as accurate as possible?
So actually, that's one of the nice things about this model, is this model is driven by hospitalizations, not number of tests. And so the degree that you're testing within a population doesn't affect these numbers. It's the number of hospitalizations we're seeing is what this is based off, and what the projections are based off of. And so that's one, going back to your question, well, we've had a couple days here where we've got fewer cases. yes, but actually the number of hospitalizations we've had are actually going up at a pretty steady incline. And so it's more the number of hospitalizations. That's the objective finding, because I could shut down the number of cases in the city tomorrow just by cutting down the number of tests that I do, but I can't shut down the number of hospitalizations, and that's what drives the modeling.
Thank you. And if I could, one more thing for self-preservation when I get home. There is a difference between a clinic nurse and an ICU nurse, so that's more for my self-preservation, so thank you.
Covered. Before we go around again, Councilor Brecky or Sale, I believe, do we have any questions from you? Just checking while you're on the phone.
Councilor Brecky.
Okay.
This is Councilor Brecky.
Go ahead.
Yeah, I really don't have any additional questions, and I really just want to thank my fellow council members. You guys really asked some terrific questions and really fleshed out the presentation that we had in a way that I think has been beneficial, certainly for me and for any other folks that are watching from home. So I don't have any further questions, but I do thank all the council members there for the questions that they asked, because that really covered all the things that I had in my notes that I wanted to ask as well. And I thank all the doctors and staff for your due diligence, and I am a fan of modeling, and I am a fan of these are the kinds of things that give me confidence. So, and this kind of a presentation helps me, proceed with confidence. So I thank everyone for your efforts.
Councilor Erickson.
Thank you. I just have a couple more questions. First, I hate that we say 20 to 80%. It reminds me of the snow forecast in South Dakota most times, where we're going to get 2 inches to 14 inches. It's just a frustrating area to be in with confidence, but also knowing that so many will be asymptomatic that a lot of people may even have had it and not realized. And so it's just a unique place to be in. I'm curious a little bit if someone can comment a little bit on, as the positive test increases, so does the daily recovery rate. And if we're tracking the difference with that, because it was almost equal today. It was real darn close to being equal, which in a really crappy situation, we've got to focus on a couple of those little benefits of saying, great, this was a great day. Tomorrow might really be terrible. We might have 300 more cases, but I'd like somebody to talk through how that data is being tracked as far as recovery rates with the positive rates, and maybe even potentially having some charts with that. And then I'll ask one more question that whomever wants to speak to it. I took a call today from a nurse who was furloughed. And so my questions to the hospital systems, not to put you on the spot, and I feel a little bit bad at asking this question publicly, but I'm hearing that there's several furloughed hospital system employees, many that don't have anything to do because we're gearing up for this and all the elective surgeries that aren't taking place. I do have a couple friends that work in elective surgery areas that are no longer working as well. And so that's a different sector of your hospital systems, but talk a little bit about the furloughed employees, if they can be repurposed into this, or if that's not even an option, because we want people to be safe too. So those two things as far as recovery rates and then the furloughed employees.
I won't answer that question, the second one, but I can talk a little bit about the first question. And when we talk about recovered cases, Counselor, that is something that, we know we see those recovered cases on the state's website, and that's good. And it is, you're exactly right. We have total cases. It's our best measure right now of really being able to see where we're going to trend with the surge, and that's why we're tracking it that way. As has been described already, hospitalization rates and ICU bed capacity and demand are going to be the things that we'll really be working with the health systems to monitor in this next operational period.
Thank you.